this time because there were certain classes that had to be adjusted. And this time we'll be running these two sessions side by side. Actually, this is, I think, a better way of doing things. We can combine the hepatic vascular interventions in two classes today and tomorrow. We might need a third one for the hepatic venous interventions. I will try to definitely cover hepatic arterial interventions today. And maybe if we can start portal uh, interventions as well. If not, then maybe we'll divide it into three classes. We might try to combine these two and keep hepatic venous separate, but I'll try to go slow because there's no point of rushing, as perhaps not everybody is at the same level of understanding. So as we go, I told you vascular interventions will be divided into what we do through these three blood vessels, because there are three different types of blood vessels, two which bring blood to the liver and one which takes it away. So hepatic arterial and portal venous is the one supply that goes to the liver. So this is very special point for liver. It has dual supply. So that allows us a lot of leeway to, do things where we can kind of um, try and close certain vessels and still have the availability of blood supply. We may not cause an infarct. So all these things are possible only because of the dual supply of the liver. And also this supply itself has a differential way of supplying the tumor and the normal liver. So that is one of the very, very important points that we utilize in the vascular supply or the vascular treatments of hepatocellular carcinoma. So from here, we'll move towards the arterial interventions. So arterial interventions can be divided into either embolization. Embolization is basically shutting down a blood vessel on purpose. And if we do it for a tumor, then it's tumor embolization. Or if there is an arterial injury or a bleeder, then it's primarily a vascular vessel-related embolization. In tumor, we will be covering the basic conventional transarterial chemoembolization, the drug-eluting bead, DEB-TACE, and the transarterial radioembolization. These are the primary three things that you must understand. TA is basically when we don't want to use chemotherapy, we are just primarily planning to reduce the blood supply. Say maybe there is an exophytic lesion in the liver, which can rupture and cause bleeding. So, or it has ruptured recently and caused bleeding, and we can kind of just embolize because it's not with the intent of treatment. Maybe it's a large tumor, but to make sure that there is hemostasis. And infusion has been used on and off, but again, not very important at the level of the MD students. Vascular, again, pseudoaneurysms, they may be traumatic. Pseudoaneurysms, they may be iatrogenic, like say maybe doing a cholecystectomy, or somebody was trying to put a pigtail only and hit the artery. Then inflammation related to an abscess, which has caused erosion of the vessels, pancreatitis related pseudoaneurysms. And sometimes you can cause fistulas. Fistulas is not something, again, I'll be stressing too much upon, because first you need to identify the basics. What is definitely expected of you is embolization of tumors and basic pseudoaneurysms. Then the second and third component are primarily seen in hepatic transplant patients, that is stenosis of the transplant hepatic artery or thrombosis of the hepatic transplant artery. Will be briefly touching upon that so that you can include that in your answer. And if somebody asks you, you should know that this kind of entity is also there. The next thing is focus on this. This is definitely a probable question in MD. This is something that you will do if you do think about going into interventions, and it is definitely there to stay. So embolization for tumors, this was the first thing that we started doing, was conventional TACE. TACE is transarterial chemoembolization. As I told you previously, transarterial chemoembolization is possible because the tumor is primarily supplied. More than 95-99% of its supply is from the artery. Whereas the liver, primary liver that is there, is going to have both the hepatic portal venous supply as well as the hepatic artery. So if we shut down the hepatic artery or we put medicine into the hepatic artery, it will primarily affect the tumor. So if we put some medication which is not so selectively put into the specific tumor artery, maybe a bit of chemotherapy related side effects, will happen to the rest of the normal liver, but the normal liver will not have any ischemia because the portal vein is still there. So be very clear about this, that the portal vein is there. That is why we can do TACE in liver whenever there is significant portal vein thrombosis, a main portal vein thrombosis, or a branch, right or left, main branch of the same side where you are planning to do the arterial embolization. That is a contraindication for the conventional or the DEB TACE. We will talk about tear. That is something that you can do in those cases because we do not block the main artery. We only do embolization at the tumor level. So that is something that we'll talk about. But otherwise, if the portal vein is closed, you can't close the artery. So if that is there, you can't really do chemoembolization. Now, initially when we started, we did not have any special beads or any special thing. It was like the conventional method where we started mixing doxorubicin. We thought, why to give the chemotherapy to the patient? It has multiple side effects. If we have this differential that the hepatic artery supply is primarily going to the tumor, then why not put the medication in that and prevent the systemic side effects? Also, you can embolize it because of the ischemia itself. It will have an effect on the tumor growth and the tumor will reduce in size and maybe even completely go away. But again, important thing to understand, chemoembolization is not a curative intent. You might get cure, but it is not considered to be done for curative intent. So basically, as I said, intra-arterial chemotherapeutic agents are mixed with oily medium, something we call lipidol. I'll be showing you the imaging. So what we create is we take doxorubicin and mix it in distilled water, and then we mix it with a oil. So we get a water in oil emulsion. So this lipidol helps in carrying the drug. It keeps and stays in the arterial circulation, and it slowly releases the drug, so that increasing the half-life. Otherwise, if you just inject the drug like this into the hepatic artery, it will go through that, go into the vein, and it will be gone. So to make sure that the drug stays there for some time, we inject this with this oily material called lipidol, and this gets deposited in the tumor bed and then slowly releases the drug. Now remember this. This will form the basis of why we go towards DEB TACE later, what is called drug-eluting beads. Primary principle, hepatic artery and portal vein both supply liver. It has dual blood supply. Hepatic artery is the primary supply of the tumor. It doesn't have portal supply. So once we put chemotherapy in that and we close that artery, the tumor doesn't get circulation, doesn't get blood supply, and the drug stays there. Why does the drug stay there? Because we try to mix it with a oily material called lipidol, which stays in the tumor and slowly releases the drug. But all of this was a lot of art. How much lipidol to mix, how much drug to take, mixing it in a specific manner, 2:1, 3:1, how these things will affect the final efficacy of the TACE. So that is the difference between conventional TACE and drug-eluting beads, where we got a more objective way of measuring all this. So that we'll be discussing when we go to DEB TACE. So we've got an idea what we are doing. The rationale, as I said, is that there is hepatic arterial supply as well as there is portal supply to the liver. So liver does not die. That is the most important thing. The advantage, as I said, greater concentration of chemotherapy as compared to giving it IV, prolonged period of time because we are mixing it with lipidol, minimizing the systemic toxicity because it's not freely going into the systemic circulation, and it tries to preserve as much of liver function as possible because we are not damaging the portal vein. So this is the treatment strategy. We need to understand which hepatic tumors do we embolize. This is the BCLC-B, BCLC staging. This is the staging that is followed for HCC. And as you see here, it may be a small tumor, then there will be multiple small tumors, or there will be multiple slightly larger tumors, or extrahepatic spread, or very diffuse HCC. That is how the staging is done. It's not like the typical TNM staging that we do for other tumors. So this is something that is important to understand. Three things are important when we are discussing a liver tumor. We don't only look at the tumor, we look at the liver and we look at the patient. So there is a component of patient, liver, and the tumor. So here you see, whenever you see a staging, it says solitary tumor less than 2 centimeter, preserved liver function, and performance status. Liver function is also mentioned, performance status of patient is also mentioned, and the tumor size is also mentioned. So less than 2 centimeter means you are a very early presenter. You can either go for resection, but resections work better when you have the tumor at one of the ends. So you can remove that segment and you still have a large rest of the liver remaining. And we know that 40% of diseased liver or 25-30% of normal liver can take up the function of the entire liver that is required for the human body. But if say this lesion is right in the center, somewhere in segment 5, then you will have to do an extended removal of the liver just for a 2 centimeter lesion. So in those cases, we can even opt for ablation. So if the person is surgical candidate, we can remove the liver, the tumor with a significant residual liver. Then we go for resection. If it's not a surgical candidate, or we don't get a very good FLR. FLR is the liver remnant that we get after resection or after surgery that is free from tumor. So if that is not adequate, then again we can do ablation. We have found that in less than 2 centimeter lesions, ablation with a 1 centimeter zone is almost as good as surgery. So remember, this is the way we'll teach early stage disease. Of course, if the patient is candidate for transplant, it can be considered for transplant also, especially if the patient's otherwise liver function is not very good and he needs transplant, other way around as well. Similarly, now the point is this way we have this entire staging. What I want you to focus on is this here, this intermediate stage HCC, which is multinodular sometimes or a single nodule more than 3 to 5 centimeters with a preserved liver function and good performance status. This is where chemoembolization is important. If it is too advanced, we go for systemic therapies like sorafenib. There are certain second line, third line immunotherapies that are there. Or if it's really early, we try to get a cure by ablation, by liver transplant, or by tumor resection or liver resection. So this is the stage which has the potential for curative intent, for palliative intent, especially to increase the overall survival. What are we going to achieve with chemoembolization? We are only going to increase the survival. We are not able to bring about a complete cure. Usually we don't call, or we don't at least tell the patient this. We might get in one odd case, but the primary agenda is to reduce the tumor burden, increase the life of the patient, and reduce the speed with which the tumor is growing. So this is the importance of this chart, that intermediate stage HCC. Somebody asked you to be clear. Intermediate stage HCC is where we use chemoembolization. All these 2-3 techniques that we talk, conventional TACE, DEB TACE, TARE, are primarily used in this BCLC-B.